textbook-style explanation of focal segmental glomerulosclerosis, FSGS, with clinical depth, pathophysiological flow, nursing perspectives, and exam-ready precision. 1. Introduction. Focal segmental glomerulosclerosis, FSGS, is a chronic progressive kidney disorder that represents a pathological pattern of injury in the glomeruli. It is characterized by segmental scarring in some, but not all, glomeruli. Clinically, FSGS is one of the most common causes of nephrotic syndrome in adults and an important cause in children. It is not a single disease, but a histological finding that can arise from many different causes, both primary idiopathic and secondary, adaptive or injury-related. If untreated, FSGS frequently leads to end-stage renal disease, ESRD, requiring dialysis or kidney transplantation. Definition: focal segmental glomerulosclerosis, FSGS, is a glomerular disease characterized histologically by focal, affecting some but not all glomeruli in the kidney biopsy sample; segmental, affecting a portion of the glomerular tuft within each involved glomerulus; glomerulo, involving the glomerular capillary network; sclerosis, scarring due to extracellular matrix accumulation and obliteration of capillary lumens. 3. Etymology. Focal, Latin focus, meaning point, here indicating that only some glomeruli are affected. Segmental, from Latin segmentum, meaning part, meaning only a part of the glomerular tuft is scarred. Glomerulo, from Latin glomus, meaning ball, refers to the spherical capillary tuft in the kidney. Sclerosis, from Greek sclerosis, meaning hardening, here due to fibrosis, scar tissue. 4. Epidemiology. Incidence increasing over the past 3 decades, partly due to rising obesity and hypertension. Prevalence 20-25% of nephrotic syndrome in adults, 10-15% in children. Ethnic distribution, highest in African Americans, linked to APOL1 genetic variants. More severe progression and poorer prognosis in this group. Gender, slight male predominance, 1.51. Age, can present at any age. Primary FSGS often in young adults, secondary adaptive types in middle-aged older adults. Prognosis, 50% progress to ESRD within 5 to 10 years if untreated. Collapsing variant progresses faster, 1 to 3 years. A, based on cause 1, primary, idiopathic, FSGS, no identifiable cause, likely due to circulating permeability factors damaging podocytes, e.g. SUPAR. 2, secondary FSGS, adaptive response to reduced nephron mass or chronic injury. Causes include hypertension, obesity, reflux nephropathy, sickle cell disease, cyanotic congenital heart disease. Genetic familial FSGS. Mutations in podocyte or basement membrane genes, MPHS1, MPHS2, ACTN4, TRPC6, often steroid resistant. 4. Virus-associated, HIV, HIV-associated nephropathy, parvovirus B19-CMV, hepatitis B. 5. Drug-induced, heroin, interferon-AS, pamidronate, lithium, sirolimus. B. Histologic variants, Columbia classification. 1. Classic NOS, 2. Tip lesion variant, better prognosis, response to steroids. 3. Perihalar variant, often in secondary adaptive forms. 4. Cellular variant, inflammatory cell infiltration. 5. Collapsing variant, severe, rapid ESRD progression. 6. Causes, primary, unknown, thought to involve immune-mediated podocyte injury. Secondary, chronic hypertension, obesity, reduced kidney mass, adaptive hyperfiltration injury. Infections, HIV, hepatitis B, C. Drugs, heroin, interferon, bisphosphonates, sickle cell anemia, cyanotic congenital heart disease. Genetic, podosin, nephrin, alpha-actinin 4 mutations. 7. Risk factors, African ancestry, AL1 variants, family history of kidney disease, male gender, hypertension, obesity, reduced nephron number, e.g. from prior kidney injury or surgical removal, HIV infection, IV drug use, long-term nephrotoxic drug use. 8. Complications, persistent nephrotic syndrome, edema, proteinuria, hypoalbuminemia, hyperlipidemia, accelerated atherosclerosis, thrombosis due to loss of antithrombin 3, progressive CKD ESRD, infections due to loss of immunoglobulins in urine, cardiovascular disease from hypertension, dyslipidemia. 9. Pathophysiology, sequence of events. 1. Podocyte injury, triggered by circulating factors, genetic defects, toxins, or hemodynamic stress. 2. Podocyte effacement, loss of slit diaphragm integrity, increased permeability to proteins. 3. Podocyte detachment, areas of denuded glomerular basement membrane. 4. Adhesion to Bowman's capsule, abnormal connection forms. 5. Segmental sclerosis, accumulation of extracellular matrix and obliteration of capillary lumens in parts of affected glomeruli. 6. Hyperfiltration injury in remaining nephrons perpetuates damage. 7. Tubulointerstitial fibrosis, final pathway to ESRD. Number 10. Signs and symptoms. Renal, proteinuria, 3.5 grab day in nephrotic range, may be subnephrotic in secondary types. Hematuria, microscopic. Foamy urine. Systemic, edema, periorbital pedal ascites. Hypertension, fatigue, malaise. Metabolic, hyperlipidemia, hypoalbuminemia. Number 11. Medical diagnosis, history and examination. Edema, BP, urine changes. Urinalysis, proteinuria, microscopic hematuria. 24-hour urine protein or spot protein creatinine ratio. Blood tests, serum creatinine, eGFR, albumin, lipids. Serology, HIV, hepatitis B, C, ANA complements. Renal ultrasound, kidney size, rule out obstruction. Renal biopsy, gold standard. Light microscopy, segmental sclerosis, hyalinosis. Immunofluorescence, IgM and C3 in sclerotic segments. Electron microscopy, podocyte effacement. Hem12, nursing diagnosis. Excess fluid volume related to impaired renal function. Imbalanced nutrition, less than body requirements related to protein loss. Risk for infection related to immunosuppressive therapy. Risk for impaired skin integrity related to edema. Fatigue related to disease process. Anxiety related to chronic illness and prognosis. 13. Medical management, proteinuria reduction, ACE inhibitors, ARBs. Blood pressure control, target 130-80 millimeter/grams. Edema management, loop diuretics, salt restriction. Immunosuppression for primary steroid-sensitive, corticosteroids, prednisone. Calcineurin inhibitors, cyclosporin, tacrolimus, mycophenolate mofetil, rituximab in resistant cases, lipid-lowering statins, anticoagulation in high thrombotic risk. 14. Nursing management, monitor fluid balance, INO chart, daily weight. Assess edema and skin turgor. Educate about low sodium, moderate protein diet. Administer medications and monitor side effects. Infection prevention, hand hygiene, avoid sick contacts. Educate about importance of BP and proteinuria monitoring. Emotional support and referral to support groups. Number 15, treatment options. Medical, ACE-ARB, diuretics, immunosuppressants, statins. Lifestyle, weight reduction, salt restriction, avoid NSAIDs, nephrotoxins. Dialysis in ESRD. Kidney transplantation may recur, especially primary FSGS. Number 16, psychosocial intervention. Psychological counseling for coping with chronic illness. Support group participation, education on self-care, diet, medication adherence, family counseling for genetic cases, assistance with healthcare access, and financial planning. Number 17, prevention. No prevention for primary forms. Prevent secondary by controlling BP, diabetes, and obesity, avoiding nephrotoxic drugs, promptly treating infections, screening high-risk individuals. Number 18, conclusion. FSGS is a significant cause of nephrotic syndrome and progressive kidney failure. While primary disease has no known cause, early detection, aggressive management of proteinuria, BP control, and addressing secondary causes can delay progression. A multidisciplinary approach involving nephrologists, nurses, dietitians, and mental health professionals is essential for improving long-term outcomes. Thank you. Have a nice day.